I'd like to introduce our next speaker, who's Professor Peter Sandercock. On my right here. Peter studied medicine at the University of Oxford and undertook his postgraduate clinical training in Stoke-on-Trent, Manchester, Oxford and Liverpool, followed by a visiting fellowship at the McMaster University in Canada. His initial research was on the epidemiology of stroke in Oxfordshire and in clinical trials of stroke. He set up the first international stroke trial, which many people in the room will be familiar with. The first mega trial in acute ischemic stroke, recruiting from 467 hospitals across 37 countries. Peter was coordinating editor of the Cochrane Stroke Research Group for over 10 years, and he still remains active in the group. He has served on many academic investigator-led stroke randomised trials, data monitoring committees and trial steering committees, and he established the Edinburgh Clinical Trials Management course and has a major role in the University of Edinburgh's Masters in Clinical Trials, which has been offered through distance learning. Peter is also chair of the International Advisory Board for the HRB TMRN, and we're very grateful for him for taking on that role, given his expertise in clinical trials and the methodology within. Thank you, Peter.
Well, thank you very much for that very glowing introduction. When I gave the title for this talk, it was a subject that was really high in my mind, I was very preoccupied. And as I was flying over this morning, I thought, this isn't really a methodology talk. And then actually what I realised was that this talk is about methodology. It's about the methodology of transparency in clinical trials. And I think actually the speakers that have come before me have really set the scene really nicely. So Mike set the scene about the importance of large trials that are big enough to answer the questions reliably and, like ISAT, to change clinical practice. That's the first thing. So you can't change clinical practice unless you've got something really worth telling the public. John Newell's talk about trying to convey that information to people, both doctors and patients, in an informative and understandable way is really important. And what the story I'm going to tell you illustrates all of these points along the way quite neatly. And then Paula follows that up with, again, the transparency of how did you decide what you measured? These are all really, really important aspects of showing that what you've collected in the way of data or a result is actually worth taking some notice of. The first bit of transparency is that I'm accused of being in league with the drug industry. And I just want to put that completely aside. Boehringer Ingelheim initially agreed to donate drug and placebo for this trial of ALTEPLASE for stroke. And then after we'd randomized 300 patients in the pilot study, said, no, we're not going to do any more. So we had to change to an open design. So they are not in my best books. And so I do resent any implication that I am a sort of, in some way, a lackey of the pharma industry. Get that out of the way. Right. So what I want to do is talk a bit about the background and history of the IST3 trial, going back to another large, simple trial, which Mike Clark also knows a lot about, mega trials in myocardial infarction. Then I want to move on to the trial that Declan mentioned that I was involved in acute stroke, and moving on then to how we handled that in relation to IST3, how that led to the trial that we did, and the steps that we took to try and be as transparent as possible, given the problems and the controversies. Touch briefly on the results, and then I want to talk about how people reacted to the results and how we tried to handle that in a sensible way, how that debate has continued, and we've tried to handle that. And then I want to finish with just a note on data sharing, because that's something everybody has to think about now, and with just some preliminary points to make about that. So in 1988, a systematic review had led to the understanding that clot-busting drugs for people with heart attacks. So heart attacks, you get a blood clot blocking the blood supply to the heart muscle, you get chest pain, and you're at high risk of dying. And a systematic review of a number of small, inconclusive studies had suggested that Clotbusters for MI would reduce early mortality within the first 5 weeks by about 22%. That did not lead to a change in clinical practice, And so two mega trials, GC in Italy and ISIS-2 internationally, were established to test streptokinase versus control and streptokinase plus aspirin and aspirin alone. And essentially what it showed was that estimate from the systematic review was absolutely spot on, but it took a trial of 17,000 patients to provide a really robust result that nobody could argue with, and practice changed overnight, much in the same ways that it did after ISAT. So with that background, and thinking about stroke, which is my own area of interest, stroke is a global problem. There are 15 million strokes a year worldwide. So if we're going to change the treatment of stroke, we need really solid evidence. And we started with a very simple treatment, which was aspirin. And so this was a treatment to be given to patients at the front door of the hospital within the first 48 hours at the start of the symptoms. And we did it in collaboration with the CAST group in China. So IST was international, and CAST was done solely in China. Together we recruited 40,000 patients with acute ischemic stroke, and the bottom line was, although the effects of aspirin are modest, they did improve outcome and safety was acceptable. So those data became available in 1997, and we then started thinking about the next trial, and the natural thing to think about for acute ischemic stroke due to a blocked artery in the brain was clot-busting drugs. Now, this is a systematic review done in 2004, so this was, I'll explain a bit more in a moment, this was the evidence that was leading us to say we should evaluate this. And this comes back to Paula's point about core outcomes, because there were two outcomes that were measured in these trials. One was death, and the other was disability on a scale, which I'll talk about a bit more in a moment. So if you like, from a sort of global perspective, you want to be sure that this treatment does not kill. You want to be pretty certain it does not kill, but what you want it to do is to reduce disability in survivors. So the early trials, and notably, now I'll see if I can get this pointer to work. Well, if you look across at NIND, oh, is that, yeah, there we are. The arrow is just about next to NINDS, 1995. That was a trial, a very small trial by cardiovascular standards of 600 patients in America of ALTEPLASE, this new designer drug. And although ALTEPLASE had no effect on mortality, it did reduce disability quite substantially in people who had been treated within the first 3 hours of stroke onset, and this was hailed as hugely important. And surprisingly, the FDA licensed it on the basis of 600 patients. Now, for a drug that is to be used potentially in millions of patients, in our view, that was insufficient. It was also insufficient in the view of the European regulators, and so 2 European trials were done, ECAS-1 and ECAS-2, and immediately you can see a problem. ECAS-1 suggests this treatment increases the risk of death. ECAS-2 is neutral. So there's a lot of debate. The Americans were very clear. This was an American drug tested by American doctors in American hospitals. It works. There is no increase in death. But if you look at the confidence intervals, we politely pointed out, they don't exclude the possibility that you're killing people. So, what to do? Well, sorry, I'm going the wrong way. So, at about in about the year 2000, we had got up enough head of steam to say we should start a randomized pilot, recruiting not just people within the first 3 hours, not just people aged under 80, because all the trials had an upper age limit. We want to see, for the broader generality of acute stroke patients within the first 6 hours, what does this stuff do? What does it do to survival? What does it do to death, to disability? And this was a very controversial idea because we were talking about mega trials, which neurologists and stroke doctors didn't like. They're methodologically messy, but they changed practice. So after 4 years wrangling with the MRC, we finally got funding to do a reasonably large-scale trial. And at that stage, the evidence still was not clear what the effect on mortality was. And in fact, by 2004, when this was published, after the trial came out, 2008, I beg your pardon, there was still a non-significant excess of deaths. So this was a treatment which might be reducing disability at the cost of some extra deaths. So this is, again, really important. What matters to patients? They want to be alive without disability. But, from a broader societal perspective, you don't want a treatment that's killing too many people. So this was a large-scale, low-budget trial, which, because of the behaviour of the industry, was forced to be of an open design, which immediately caused lots of criticism. We had some basic questions. Does thrombolysis increase the number of independent survivors? Does it benefit a wider variety of patients than that defined by the very restricted licence, especially older people? But given that a third of all strokes are aged over 80, there was less than 100 people randomised over the age of 80 between treatment and control. So, it was an evidence-free zone. Yet many stroke patients might be being denied ineffective treatment because it wasn't approved for the over 80s. And of course, just at 2004, we had the European Clinical Trials Directive coming in, which was a big concern to us because in the era of ISIS and IST and CAST, you could do very simple trials at very low cost. And suddenly the European Clinical Trials Directive changed all of that. So it was prospective, randomised, controlled study, open control, done without pharma support. We started with a target of 6,000, but because of all the bureaucracy had just slowed us right down, we had huge momentum problems. And so we had to revise our target down to 3,000, which is still 4 times larger than the previous trial, largest trial, but not big enough, as you'll see in a moment. And we took as many steps as we could to minimise bias in the assessment of outcome. We assessed death from all causes at 6 and 18 months because long-term outcome after stroke matters. All the pharma trials had stopped follow-up at 3 months, and you'll see that that's a problem. And we used a very simple measure of outcome, the Oxford Handicap Scale, which I'll talk a bit more about in a moment, just by postal questionnaires sent to the patient. So, because we anticipated all sorts of problems with the shenanigans that had gone on, with the delays, with the open design and so on, we felt we had to go to be maximally transparent. Interestingly, one of our critics said, all of this stuff that we did in the interest of transparency was just lowering expectations. So we were just getting people ready for a neutral result. You can't win. So we published the protocol, we published the rationale for the protocol. The journal Trials was immensely helpful. It published our full protocol, which included a commitment to data sharing. And they also allowed us to publish an update on recruitment, the baseline data, and the various changes to the protocol that had to be introduced over the course of this trial to overcome the various difficulties we'd encountered. And in 2012, some additional saber rattling out in the jungle suggested that we were going to have to be very open about our statistical methods, even though they were in the protocol that was already published. So I spoke to Doug Altman and I said, how common is it for trials to publish their detailed statistical analysis plan? And he said, it's not very common. People aren't really interested. But the International Journal of Stroke did agree that it could be published as a supplement to a short article on the thread of publications related to a trial. And I think that's a really nice idea, that every trial should have a thread so that everything that's published about the trial can be linked on the internet. And then this happened. So before we produced any results, we had this pre-emptive strike coming across the Atlantic. In anticipation of the International Stroke Trial, slightly threatening title, from this very eminent American neurologist. And he said a really extraordinary thing for somebody who's done quite a lot of trials and research. One thing the IST3 trial results cannot do is reaffirm or refute prior trials of thrombolytic therapy, i.e. the American trial. And I took some offence at that. I mean, just doesn't make any statistical sense to me at all. So then the fun really started in 2012 when we had the main results. And as we've already heard from our statistical speaker, the world is not about p-values, it's about estimating. And that's a really important idea. Fortunately, I got the idea of estimation. So there are two camps who looked at this result. The sort of pharma-trained people said it's a neutral trial. It tells us nothing about what to do with our patients. It's not statistically significant. It has failed. Fair enough. Among those allocated to control, 35% were alive and independent, and among those allocated to TPA, it was 37%, approximately 14 per thousand absolute difference. So in terms of a result, that's a modest effect. It's a bit better than aspirin in this generality of acute stroke patients. But the point estimate is probably the best estimate of what it actually does. So if you're talking about the generality of stroke patients, half of whom are aged over 80, then it has a small but definite effect. However, when you look at it given within that golden first 3 hours, just as in with heart attacks, the sooner you give it, the better it works. So among the 900-odd patients treated in the 5 trials before IST3, which have included patients within that golden 3 hours, you got a point estimate of a 1.56 odds ratio, increasing the likelihood of being alive and independent. IST3, with a similar number of patients, so about the same size as all the other trials put together, provides exactly the same point estimate. Happens to be conventionally significant, and you put all the trials together, it's conventionally significant. So that you can say, among those treated early, this is an effective treatment at improving something that matters to patients, which is being alive and not needing help to get dressed or washed or walk. So that's one piece of useful information. And some people liked that. The Americans liked it. Dr. Lydon became converted to the idea that maybe IST was okay after all. And moving on now to trying to explain to doctors what this stuff does. And the two things here. Firstly, IST was different because we're interested in long-term follow-up. So we follow up patients at 6 months and 18 months. So along the top, you've got 2 bars, which is the distribution of this score. So if you're OHS, Oxford Handicap Scale, 0 or 1, you've got really no significant symptoms. You can do pretty much what you need to do. And if you're 4 or 5, you're very disabled but alive. And if you're 6, you're dead. So this summarizes both the bad stuff, the deaths, and the severe disabilities. And what you can see is that C is the top line, TPA is the one below, that is thrombolysis. And thrombolysis, although it does not increase overall mortality, shifts everybody towards a lesser degree of disability. And so that looks like a useful result. And what's nice is that when you follow up people a year later, that shift persists, so it's a worthwhile benefit that lasts. There are more deaths, but again, the deaths are equal between the 2 groups. The next thing, and again, this comes back to routine use of routine data in clinical trials. So we were very keen, because we had participation in Nordic countries that could do long-term follow-up, to look at long-term survival. And this is some work which was published last year, looking at the survival curves, cumulative mortality curves, in patients who arrived at the hospital with a mild stroke in green, and people with a severe stroke who arrived and were in the trial in red. And I don't know if you can see the lines, but looking at the lower green line first, obviously if you've got a mild stroke, your cumulative mortality over the first 18 months after the stroke is low. But what you can see just above the solid line, so the solid line is the controls, the dotted line is the treated group. So they had an early hazard, mostly due to bleeding in the brain, and they never, the treated group never picked up, they never overtook the control group. Whereas in the severe strokes, again, similar early hazard from fatal intracranial hemorrhage, but because we suspect of reduced disability in survivors, among severe strokes, a mortality advantage begins to appear from the treatment. So the effects on mortality are interesting, and if you censor the curve at 90 days, which is on the left-hand side of that graph, you can see you're missing a lot of useful information. So pharma trials, by not making use of routinely collected data on an outcome that is really important, have missed a trick. Okay, so there's some results which have helped doctors decide what to do with treatment, how to inform patients about the risks and the benefits. And so I'm delighted that the Edinburgh Evening News puts my picture in the paper, breakthrough after capital team stroke drug trial. Somewhat overstating the case, but never mind. And the guidelines picked up the results quickly and incorporated the results in the guidance. So that was all very good. The Lancet published it. The broadsheets were generally pretty reasonable. And then the trouble started. There's a faction, we call them the flat earthers, who are affiliated with emergency medicine. I hope there aren't too many emergency medicine doctors in the room. And for some reason, for reasons which are not at all clear, but nothing to do with evidence, produce stuff like this. Delusions of benefit in the International Stroke Trial. Results of the largest and arguably most important trial, thank you, of thrombolysis in acute stroke were in the Lancet. And the study's conclusions are breathtaking. Not because the study results, which are unsurprising, i.e. negative, but because the author's conclusions suggest they've gone stark staring, raving mad. Now, when you've just slaved for the best part of 20 years to produce what is a reasonable piece of evidence, this doesn't go down well with the chief investigator, i.e. me. I just found it quite difficult to cope with this. And Twitter, of course, went crazy on the plus side and on the negative side. And, here we are, we've got all sorts of negative stuff happening on Twitter. But I haven't put up the positive stuff. And so as a chief investigator, that is something you have to deal with. And I'll come back to that in a minute. This was more worrying. And this relates to a small number of physicians, including, I have to say, with regret, Sir Richard Thompson, the former president of the Royal College of Physicians of England, who joined a group of people who were sceptical. And this led to, they were led by a retired geriatrician who's never used thrombolysis, Dr. Roger Shinton, who has led a campaign to try and get the marketing authorization for ALTEPLASE removed. And it led to this paper in the Times, whose headline is "Standing Up for Transparency, a clot-busting drug given to stroke patients is being blamed for thousands of extra deaths." Nobody said that this treatment was not associated with an early hazard. There are claims that stroke physicians have been misled about its risks. Well, we were pretty transparent in the Lancet, I have to say. Shinton is concerned that ALTEPLASE is causing a significant number of additional fatal bleeds. We said so in the Lancet. The risk is 4%. That's what we put in the patient information leaflet. If you're randomized in this trial, your chances of having a fatal intracranial bleed are about 4%. So the justification for lack of transparency just isn't there. And then, in the interest of transparency, he declined to comment ahead of publication of his findings. His findings were published in the form of a 2-paragraph letter in the Lancet, which didn't contain anything about any of this. And so, but what that did was it led to a review by the MHRA into the safety of TPA. And I'm relieved to say that actually the MHRA went through everything with a fine-tooth comb, and they decided that the license should stand sensibly. And interestingly, having reviewed the data from IST3, they said actually the current contraindication in the license for patients over 80 should be re-evaluated in the light of new evidence. So I felt vindicated. But, these things are sent to try us. Moving on to a more positive note, the Institute of Medicine in America, and of course in the MRC and other funding agencies, are all completely signed up to the idea that we should foster a culture in which data sharing is the expected norm. Now, the problem is that that has been communicated, and we have all trials, and we have drug companies releasing all of their data and so on. But if you've run an investigator-led trial funded by the MRC, and you've got a group of people who want to produce publications and so on, there are some practical difficulties about how you actually implement data sharing. And what we had decided to do was, following Mike Clark's example with the early breast cancer trialist collaboration and all the individual patient data meta-analyses that he's run, is you get the people who've done the trials together and say, do we agree that we can put together our data in an individual patient data meta-analysis? And that took me 5 years' work to get all of those pharma trialists and the Americans round the table to agree to share their data in a pool. We managed that, and this photograph is my favourite photograph because the bottom right photograph, this is me giving Boehringer Ingelheim a copy of the IST3 data set, and Erich Blumke from Boehringer Ingelheim giving me a copy of all the other trials. And we then gave it all of that to the Oxford group, led by Colin Bagent, and that's led to a very nice primary publication in the Lancet just last year, looking at all of the data by a completely independent group who have been, I have to say, forensic in going through our data, and it's been okay, so that's good. And the pharma data is fine too. But what this leads us on to is where next. Now, when we did IST1, that was a low-cost trial. It was published in 1997, and it's been around for ages. So I just decided, I wrote to Doug Altman and said, well, why don't we just put this on trials? Just send you the whole data file. And so that was published on trials. There were some issues with fully anonymizing it up to the current standard of anonymization, and actually doing that introduced some errors which then had to be corrected. But essentially that data sits there, and it's been used for all sorts of things, for statistical projects, for modeling stuff, and so on. So it's definitely worth doing. I'm signed up to doing it. The trouble is, for IST3, which is a very controversial trial, there are lots of concerns about vexatious requests. So Jerome Hoffman, an emergency medicine physician, has done some very, very inappropriate analyses of the American trial and published that as part of the argument for saying that thrombolysis doesn't work. Matt Sides has written a very nice paper in Trials talking about to what extent should you control access to your data? Is it reasonable to have a degree of control? And I think that's a point to discuss. Who pays for the cost of preparing data? IST3 was done but funded at a time when data sharing wasn't a cost issue. How are we now in the current era of research governance and data governance to make sure that the data are really kept safe and that everything is preserved as it ought to be? And how does that interact with ongoing data collection in our case, because we're continuing to collect mortality data and we're continuing to link the trial data set to routinely collected data to collect resource usage data and so on. So there are some complexities which we haven't got time to go into now. And then the unrealistic expectations. So the extraordinary thing about Dr. Roger Shinton was that for all that he was saying, we're not being given the data, I never actually received a written request for the IST data, for which there is a mechanism. There's a committee which will look at all requests to view the data or analyse the data or for additional analyses, but we've never actually received a formal request from this person who says we're not releasing the data. So through all of these trials and travails, this government message from World War II has always been very helpful. And it's helpful to anybody who ever decides to be a chief investigator. So what do we learn from all of this? Well, I think transparency is everything, and now the idea of a thread of publications leading up to a results paper and beyond is really important. Running your trial, of course, you've got to get your data as complete as possible. Always do what you said you would do, and that will defend you to some extent. And actually, I realised that what you do is you don't bother to worry about the trolls. You just don't give them the space. just let the published data speak for themselves, and by and large that works pretty well. There is an issue about how you control access to your data, or at what point you release it fully into the public domain, and that's an issue for debate. And I think some restrictions are reasonable, at least in the first years, and for this sort of trial, I'm not sure that immediately sticking it on the internet is appropriate. But there are lots of people who think that everybody should have immediate access to all data of all trials, and I thought that's a point to be debated. And this is just the acknowledgements to everyone that supported the IST3 trial. Thank you very much.